Today we are going to study in giant cell tumor. Just in a 5 minutes we'll revise it. Okay, so it is a definition. We look for the definition. It is a primary, but it is generally benign. Okay, remember, but don't think it is just simple benign. It is like a locally aggressive. It is locally aggressive bone tumor that is composed of neoplastic mononuclear stromal cells. So this is a neoplastic, okay, cancerous cell. That is a here stromal cell is the cancerous cell. Okay. Now coming to the, and this stromal cell will recruit the osteoclast like multinucleated giant cells. So it is not the osteoclast, but it is looking like a osteoclast like multinucleated giant cells will be recruited, and hence it will be typically arising in the epiphysis of the long bones, and only it happens after the skeletal maturity is attained. Okay, if we will see the ages that is affected, 20 to 40 years, mostly predominance in the females with the ratio of 1.5:1, and then coming to the like of all the bone tumors, it is having 5% incidence. And if you see like this malignant, the turning the giant cell into malignancy is most commonly in the male. Okay, so now sites, we'll look for the sites. So mostly it is a solitary, one, and it is present in the distal end of the femur, tibia, proximal and distal both, and coming to the radial bone, distal part, and humerus we are seeing in the upper end. Okay, now how it progresses. So it progresses from the like side. First it is epiphysis, okay, then it is subarticular, and then it becomes eccentric. Okay, now coming to the clinical features, if you see the symptoms and signs, the symptoms will be the most important is the pain. Okay, so it is a painful, and the swelling, if it is a skin over here, and suppose swelling is there, so it will give rise to it, and so there will be stressed skin, and the skin will be shiny, but remember there won't be any engorged veins or something will not be there. Okay, like that. Now, and here the joint movement will be decreased, and sometimes the pathological fracture can happen. Okay, so this is the picture I will show you in the diagram. So here is the diagram that we are seeing here. Suppose this is the distal end of femur, here affected, here is giant cell tumor, and so it will give the joint restriction, that the mobility will be restricted. Obviously if it is increasing in size, and so if it is skin is there, so we will be looking the stressed skin and shiny skin. Okay, and sometimes pathological fracture can also happen over here. Okay, now coming to the signs. Signs will be form to hard swelling, which we will see. Okay, on examination, and warmth will be present over there, tenderness we can elicit, and the restricted adjacent joint motion will be seen. Okay, so these are the things the signs. Now coming to the some investigations. Okay, so before going to the investigation, I have missed one part, that is the etiopathogenesis. So we'll look into the what is the etiopatology. So let's see. So already I told that stromal cell is the neoplastic over here. So what happens that this stromal cell will overexpress the rank L. Okay, now this rank L will go and bind to the rank. This rank is present on the osteoclast precursor. This is the osteoclast precursor. Here it is present. Okay, rank. Okay, and then here the rank will come and bind. Once it is bind with combined, the rank is bind with this rank present on the osteoclast precursor, so there will be the massive osteoclast activation. Okay, now, and this will do the aggressive osteolysis. Okay, now this was the simple etiopatology. Now coming to the investigation. So remember, always the blood investigation is important. Okay, why? Because I will tell you, in the giant cell tumor, the DDs, if you look, differential diagnosis that we think can be chondroblastoma, brown tumor, and telangiectatic osteosarcoma. So in this brown tumor, you know, this, if you take the biopsy of this tumor, then also it will resemble like the you can't differentiate that it is a brown tumor or not. So always remember, this brown tumor is in the hyperparathyroidism. So to rule that, and this we are doing some blood investigation, that is serum calcium, phosphorus, and alkaline phosphatase. Okay, just to rule out it is the pathology is parathyroid or not. Okay, then next comes the radiology. Obviously we'll have the soap bubble experience in X-ray. We will find the eccentric lesion, okay, that we have already seen here. Next, and then we will find out the location, where is the location, and then we will see the like if it is expanded subarticular bone up to this all sites will be looked here. Okay, now subarticular expansile, and then we will see the margins. Okay, whether which margins it is affected or not, non-sclerotic margins. Okay, like that, and then we will see any cortical thinning is there or not. Okay, any cortical thinning or breach is there or not. Now, so cortical, you already know, this is the bone. Suppose so this is the medulla in the middle part, and this is the cortex. Okay, this cortical thinning we will observe in that. Okay, always remember there is no periosteal reaction unless there is a pathological fracture. Okay. The next investigation includes the MRI. In MRI, we are having like we are only just looking for the intraosseous extension. Okay. Now, sometimes we can do open incisional biopsy also. Okay. Now, I would like to draw your attention in the investigation, like in the clinical features. This egg cell crackling was there. Okay. So, if there is a too thin cortex, so in the science we can find out this egg cell crackling sound. Okay. Always remember this. Now coming to the CT, the last thing that is we can preoperativity, we always need this. Then for the cortical breach, okay, and always if the like bones like pelvic is involved, okay, then any spinal lesions are there. In that we took the CT, okay, do the extent of the tumor and all. So always we do CT, okay, for that in that case. So find the soft tissue involvement and all. So coming to the since we are discussing the radiology, so we are seeing radio. We want to know one Campanacci grading. It's very simple. It divides into 1, 2, and 3. So in Campanacci there is a well-defined margin, okay, and the cortex is not affected. Okay, this bone, so the cortex is not affected. Okay. So in grade 2, there is expanded lesion. Now the lesion has been expanded over there, since because it is locally aggressive. Already the definition is no. And in the here you can see the thin cortex. The cortex will be thin. Okay. Now third is the cortical destruction. Finally, as pathological fracture, whatever you can see like that. So the soft tissue mass also is involved. So aggressive. So third is the aggressive tumor. Understood? Looking into the histopathology, if you see the microscopic feature and immunohistochemistry will be in microscopic feature, giant cells will be increased, okay, and if you see the obviously giant cell will be multinucleated, uniform distribution will be there. In the background we will see the spindle shaped stromal cells you will see, and this giant cell will be resembling like a osteoclast. Okay, in immunohistochemistry you will see the stromal cell with obviously RNKL positive, and this giant cell will be CD68 positive marker. Okay, now coming to the treatment part. Okay, since the investigation, the classification, histopathology, immunohistochemistry is over, so we are going for the treatment part. Now coming to the treatment is a grade 1 and grade 2. This thing Campanacci grading. If it's a grade 1 and grade 2, I have not put all the important that is written in the Maheshwari or some, but just to be overview of the treatment part. If you want more, remember, just go and look for the Maheshwari, okay, the name of the surgeries and all. Just I would like to tell you, if it is grade 1 and grade 2, we are doing extended intralesional curettage. Just remember this thing. Now coming to in surgery, we are doing en bloc resection in grade 3 condition, and always remember this alone itself is not enough. Along that we are adding adjuvant, so phenol S2 hydrogen peroxide also used at the site, and also we are giving the medical management like bisphosphonates. Always remember this zoletronic acid, because its zoletronic acid will induce the apoptosis of the osteoclastic cells, okay, of the giant cells. Understood? And now coming to the Denosumab, this is a monoclonal antibody. These are RNKL inhibitors. Always remember this. Okay, sometimes we can do radiotherapy also when surgery is impossible. And always remember, I have highlighted this point, embolization of the feeding vessels is very important. Sometimes if we are not able to approach to the tumor site, so we are trying to do the embolization, because it's a tumor, right? Tumor, how it grows, it needs a blood vessels. Okay, in pathology we have studied how the tumor is formed, right? So this arteries need to be embolized, artery needs to be stopped. So already the tumor size will be reduced, okay? The growth will be hindered. So like this we can opt out. Always remember, I have written one thing, the complications or what we're like in this we see the lung metastasis. So lung metastasis is seen, is very important. So this was the giant cell tumor. Okay.